Many thanks, Madam Deputy Speaker. I'd like to start by thanking the Youth Select Committee for what is an excellent and comprehensive report compiled by our young parliamentarians with experienced evidence. It's extremely thorough and I think it's a credit to them. I'd also like to thank the Backbench Business Committee for bringing and scheduling this debate alongside the Honourable Member for Dulwich and West Norwood. I must begin by declaring a professional interest, having worked as a clinical psychologist for 20 years in mental health. I continue to maintain my skills and engagement in line with the professional requirements of my registration. I also had the real privilege of contributing to the evidence taken by the Youth Select Committee during its inquiry into child and adolescent mental health services just after election. Mental health is an extremely wide field, ranging from major mental illnesses such as psychosis to depression and anxiety, trauma, eating and adjustment disorders. Childhood developmental disorders such as attention deficit hyperactivity disorder and autistic spectrum disorder are also often included in the sphere of mental health. And I would welcome future debates on those important conditions too, because I feel that we shall not have time to do them justice today. As a member of the All-Party Parliamentary Group on Autism, I have a particular interest in this field and would also commend the recent report from Ambitious About Autism. It highlights, which is worrying for us all, that 80% of children with autism experience anxiety every single day attending school. Such a critical group, we must target our resources and make sure that early diagnosis and support for the young child and for the whole family to understand and gain support is provided. We know that more than half of mental ill health starts before the age of 14 and 75% before the age of 18. Both early intervention and prevention of mental ill health during childhood are therefore key, absolutely critical in relation to reducing morbidity, in relation to enabling effective interventions, because the quicker we intervene, the more effectively we intervene, and also in terms of NHS cost effectiveness. In 2014, the Health Improvement Efficiency Access Targets were adopted in Scotland and across the UK, meaning that patients should be seen from referral to assessment in 18 weeks, including in CAMHS services. The figure that I have researched suggests that in Scotland 84% of children and adolescents are now treated within this time. The benchmark we've set is 90%, so we have come a long way in this regard, but we still have further to travel. There are now significantly increased referral rates, which may mean increased figures, but may also actually mean that stigma is reducing and people feel more able to present, so a mixed picture. Mental health services in Scotland and across the UK are not the finished article. We should be continually striving towards improvement, and that should always be guided by patient need and by research underpinning most effective clinical practice. As we've heard, mental health problems in childhood are extremely serious. At worst, they can destroy educational potential. And, at least they can impede it, and they can impede relations with peers and within the family. This is critical. We must address these issues. They can also, as we've heard today, lead to suicide and self-harm. Difficulties, I say again, must be assessed and recognised at an early stage. Widespread staff training has been undertaken in Scotland to try to ensure that we can pick up upon mental health issues within this age group. Cognitive behaviour therapy, family therapy, interpersonal therapy and specialist interventions such as for eating disorders, with a focus on seeing patients as close to home as possible, have been rolled out. We must make continual progress. I would say that there requires to be additional resourcing for Tier 4 services for inpatients. Inpatient treatment in itself should, for children and adolescents, be a very last resort, because it takes children away from the family home. It pathologises their difficulties. Best practice highlights intensive outreach approaches enabling children to be seen at home and treated in their natural environment, so maximising key family and peer supports. Children who need inpatient services may suffer psychosis, intractable eating disorders, or severe obsessive-compulsive disorders and a variety of neurological conditions. Currently, there are 48 beds available in Scotland, and £8 million has been pledged to build a new unit for children and adolescents with mental health problems in Dundee. We must ensure that service provision meets need. My clinical experience also suggests a lack of Tier 4 beds in forensic and learning disability child and adolescent mental health services, and I believe that that should also be addressed. Moving back to the report, I welcome it and I welcome its findings. There needs to be better communication channels between departments when children's care is transferred between professionals, and also importantly, as has been described, at key stages of development, such as moving from adolescence to adult services. There requires to be a component of the training programme for general practitioners in primary care, identifying children's mental health issues, and I would include also symptoms of autistic spectrum disorder and attention deficit hyperactivity disorder within that training, because we need to shorten the time from presentation to referral, and picking up symptoms timelessly assists greatly with this. As with diet and exercise, good mental health and well-being has to be normalised. These are all fundamental coping skills that impact upon everyday aspects of our functioning and deserve more of a health and well-being slant rather than a diagnosis one. So access to mental health specialists in schools is merited, as well as mental health awareness and training, and particularly training for staff in schools so that they can pick up at a very early stage if someone is experiencing a mental health problem and help them to access services. Specialist training for teachers would be a positive step forward. Education for children is also crucial so that they can identify when they are struggling, they can identify what makes for good mental well-being, and they can seek help when needed, or they can identify if a peer is struggling. Young people like to be involved and should be involved in their care fully. We also need to modernise our approaches to mental health services for children and adolescents and embrace the IT and social media method of communicating with young people, because it's the modern world and it's often where they communicate from. There is a project in Scotland, which I've mentioned before in other debates, called SafeSpot, an application website and school intervention to promote positive coping skills, safety planning and access to information about mental health services for young people. This is a good step forward, and I'm aware that recommendations for online standardisation and approval of resources would be a key step. We must also, as has been mentioned, address bullying, and particularly online bullying, which appears to be on the increase and very, very badly affecting children's lives. In fact, everywhere, Madam Deputy Speaker, must we address bullying. Only this summer, when I was discussing mental health, was I informed by an MP who's a peer in a delegation that I was on, that MPs have a high suicide rate, which was something that I was unaware of myself. We must lead by example. We must ensure that mental health and well-being is addressed in all aspects of life and provide a role model. There remains a lack of empirical data regarding effective interventions for young people with comorbidity issues, by which I mean mental health difficulties coupled with learning difficulties or substance use, and that requires to be built upon through future research and treatment programmes. I would also like to just touch upon services for looked after and accommodated children, because those are some of the most severely disadvantaged children in terms of services and the magnitude of difficulties that they present with, particularly those who may also have violence risk needs or self-harm needs. Further service provision for specialist groups and underpinning research are crucial, and I'm extremely pleased that the First Minister is going to be pledging to support these groups. Given that the weight of evidence for child and adolescent mental health services is in favour of psychological rather than pharmacological interventions for the majority of the presentations, clear structures need to be in place to support the delivery of effective, evidence-based psychological therapies for children and adolescents. Child and adolescent mental health services psychology posts have doubled in Scotland, and I welcome that, but once again I feel that we need to continue and strengthen this progress. Those from socially disadvantaged backgrounds have always tended also to have a poorer uptake of these services, and in these cases an assertive outreach approach may be required so that some of the most vulnerable and disadvantaged children and families do not slip through the net. So to summarise, mental health services do require parity of esteem and therefore require considerable funding. This is, I feel, beyond party politics. It's crucial we tackle this meaningfully in a cross-party manner, sharing best practice across the whole of the United Kingdom. We need real progress to reach children and adolescents and to help all of our children achieve their full potential.